Do we have too much government? We need to put people ahead of corporate profits. This system is so lopsided. This threat is a real threat to democracy.
And I think that's really important. That's something we haven't been doing in this country for a long time.
Where do you start? What do you do? How do you do it?
Access to Democracy and other Eagan community television programming is supported by Thomson Reuters, makers of Westlaw Next and based in Eagan. Through Westlaw Next and other innovative online services, Thomson Reuters is the world's leading source of intelligent information for businesses and professionals. Online at thomsonreuters.com. And by U.S. Federal Credit Union, the member-owned financial institution offering service, value, and experience you can trust to the greater Twin Cities community.
Access to Democracy returns, and Alan Miller returns, actually returns from a great trip to Mexico, and we have a return guest who I hope will become a regular, Dr. Charles Crutchfield, one of the nation's top dermatologists, and that's not my designation, that's the designation of his peers. But you're one of the nation's best employers. You're one of the nation's best offices for women. So you have a lot of things going for you.
Well, that's very kind. That sounds so good. I want to work for that office. But no, thank you so much for having me back. It's always a pleasure to be here.
No, it's a pleasure. And there's so much to talk about in terms of dermatology today. And I know we talked last time, but we didn't really get a chance to see some of the things that you have accomplished. So you sent over a chart of various skin conditions, and maybe we could bring that up and you can explain the different skin conditions, and then we're going to look at some examples of some people who have really, really prospered under that. Can we bring up that last chart, 26, I think it is? Hopefully. There we go. Okay. Tell us what we see there.
We're really kind of looking at a cross-section of the skin, and this one is a good example of acne. Acne is kind of it's a sophisticated disease. I remember when I was in medical school, a lot of my classmates would kind of tease me and say, oh, you're going to chase warts and pimples and things like that, but acne really has a profound effect on self-esteem and self-value. And so you're looking at a cross-section, and most of our skin, if you look carefully at your skin, you can see on your face little tiny pores. And at one point, we were covered with fur all over, and over time, most of those hairs have become real small. But if you look at the little pores in the skin, they're kind of like a little tube that opens up onto the surface. And at the very bottom of the tube on the side, if you look at the top left picture, you can see kind of those yellow areas, and that's oil. Those are oil glands, and they produce oil that goes into the tube and comes out on the skin to kind of coat and protect the skin. There's also a hair that's in the tube too that comes out, but over time, most of those hairs have become very small. Inside the tube itself are little skin cells, and over time, especially under the influence of hormones, those cells kind of get sticky and they clump up and they can plug the area. And the reason they become sticky is hormones. And when do hormones change? When you become a teenager. And when does acne flare up? When you become a teenager. And so that's why you usually see acne as you enter adolescence. And so what happens is the pores on the skin, especially where there's a lot of oil production on the upper chest and face and back, they become plugged, and also bacteria will come in the area, and the bacteria like to eat the oil. And bacteria also produce things called free fatty acids, and that makes the skin really, really hot and inflamed. And so those are the different causes of acne, and those are some of the things you can treat. You can unplug the pores, you can decrease the bacteria, you can decrease inflammation, you can also decrease oil production because that's building up behind the little plug. So that's kind of the different ways that acne is caused. But the main thing, it's under the influence of hormones, and it starts in adolescence.
You've got on the top right also you have blackhead.
Yep, and so what happens is sometimes the oil, when it gets plugged up, the oil on the surface becomes oxidized, just like metal will rust. The oil will rust too, and it turns dark, and that's when you look very carefully at the skin, and you can see a blackhead. Also, when there's lots of inflammation, you call in helper cells from your immune system called neutrophils. They come in, they're like the cavalry, and they come in to save the day, but a lot of times they die, and when they die, they turn into pus, and that's why you have little pustules with acne too. So sometimes you don't oxidize, and just a little white area, and that's called a whitehead. So in acne, some of the pre-lesions are called blackheads and whiteheads commonly.
You brought us some pictures of some of the young people that you have treated, primarily young people.
Yes.
And let's go with the, I think it's number 24 first. I picked that one to go with first because there's a young lady that really, really was disfigured. And certainly, you talk about loss of self-esteem, certainly felt very, very insecure. Now, she came to you, and there she is on the right. Tell us about the treatment for that.
Well, I think some of the things that are interesting to note, a lot of people think that if you have really severe acne, when you have the deep nodules and bumps, so it's called nodulocystic acne with inflammation and pustules like she had, a lot of people are worried that it will cause permanent scarring, but I think if you treat it early and if you treat it appropriately, you can see on the right that the scarring is minimal to non-existent. And in her particular case, we used several different approaches to treating her acne until we finally got it clear. But I always tell patients, and this is one of the most important things that very few patients and actually very few physicians understand when it comes to treating acne. As we talked about in the initial slide, the little follicles become plugged, so you can use medicines to unplug it. And things that are really good at that are agents that contain retinols or vitamin A products. That kind of breaks up the plugs. It also makes the cells so they're not so sticky. So retinols are commonly known as, the old time we called it Retin-A, that was one, but they have different ones now, adapalene and different things like that. So that helps unplug the pores. It also makes the cells not so sticky, and that's a good treatment. So we usually start with a topical retinol or vitamin A cream and see how that works. But one of the most important things to realize when you're treating acne is the vast majority of medicines that we use are designed to make acne better. They are not, I repeat, they are not designed to make it completely clear. And that's what's always so confusing, because the patient will go see their physician and say, I need some medicine for my problem, and it doesn't clear it up. So they'll go for a follow-up appointment, and the physician, she'll say, well, how are things going? And the patient say, well, they're better, but I still have acne. And the physician might say, well, here, try this. You come back a few months later, how's it going? Well, it's better, and then it kind of stopped working, and I still have acne. Here, try this. Well, the key is most of those medicines are doing exactly what they're designed to do, make it better. Now, the interesting thing, too, is I will give a medicine to one patient for acne, and they'll get 80 or 90 or 95% better. And I can give the same medicine to a different patient, and they're only 10 or 15% better. So a lot of it has to do with your skin chemistry and skin genetics and how it interacts with the medications that we're giving.
The difference in that young woman was just incredible, and I'm sure it turned her life around.
She was very appreciative, and we were also very appreciative to help her out. And, earlier in the program you had mentioned that, we'd been recognized for a clinic for treating women and doing things, and really a lot of that has to do with my superlative staff. And as you know, it's tough to do anything well unless you've got a great support staff. So I really take my hat off to all of our support staff and nursing staff and everything else.
That's why I won't let me do anything but sit in this chair. I won't let me near the equipment here.
I understand. So, but in her particular case, when it's really severe like that, you can certainly try some topical medicines to see if it clears it up to their satisfaction. But also, in her case, we used some laser treatments, and also we used an oral medication for her. So sometimes you have to get to that point.
But it's like a rebirth for that young woman who probably felt like an outcast, and then suddenly is a very attractive young woman.
Yeah, and the interesting thing is there's been some debate and discussion too that because acne is not a life-threatening disease, should it even be covered? Should the medicine be covered? It's more of a cosmetic event. But I'm sure that most people agree, in that case as an example, that it's not just a cosmetic event, it's a life-changing event.
It really is. An interesting thing about your practice is that you don't necessarily send people to the drugstore for some of these things. You actually create some of these medicines yourself and give them to them. And your reason for that, which you mentioned last time you were here, was really fascinating in terms of cost.
Yeah, I look at some of the cost of medications, and it's just absolutely outrageous. And, you know, it used to be an old thing about, don't shoot me, I'm only the piano player. Well, a lot of times we'll recommend medicine that's appropriate, and then the patient will call me and say, hey, that tube of cream was $800, and what are you doing? And so we decided to look at some of the other costs and have it compounded, and it's much more cost-effective and economical, and a lot of times we can provide the patient with a lot of the treatments and medications right in clinic. And they like it too because they don't, it's a strange system. They don't have to drive somewhere else, park their car, wait in line for 30 or 40 minutes to get the medicine. It's very, you come to see me, but you have to go somewhere else to get your treatment. So
But your background in that regard is kind of unique.
Yeah.
Because it's just not anybody who can go and create these medicines.
No, and I've got a background, I've got a degree in molecular biology and molecular genomics, and I've worked in research labs for many years. But, you know, people can certainly learn how to do it too. So we're trying to help our patients that way. And they seem to be appreciative too. They have to drive somewhere else to get the medicine. And it's a fraction of the cost.
Very, very much a fraction of the cost.
Yeah.
And let's bring up picture number 20, and we'll go through them in serial form now. If we can, okay. Tell us about this young woman.
Now, this is a condition, and it's called adult onset acne, but she has a little bit of both, teenage acne and adult onset acne. And oftentimes I'll see somebody that has a mixture of both. So what we do is that the approach is kind of twofold. We'll use a topical medicine to treat the adult onset acne, and we'll blend that also with a mild treatment to treat teenage acne. In her case, we use a combination of laser treatments and oral medications and topical cream. So we put it together, we designed it. Now, and hers was a little bit tricky because our first approach, it was a little bit better but not great. And I tell patients, it's like if you're flying a plane. If you're going from New York to LA, you just don't point the plane at LA and say go. You make minor corrections as you go until you finally get there. And in her case, we did 2 or 3 minor adjustments, but we finally got a combination of medications that works best for her, and it got it clear. So.
And when it's clear, is it clear forever, or do they have to continue to medicate?
It depends. Sometimes it stays clear forever, and sometimes patients will outgrow it. Sometimes you need to kind of suppress and stay on it longer term. And I tell patients, you know, they say, well, how long do I have to take this medicine? And I said, well, you know, sometimes the question's analogous. So how long do I have to take my blood pressure medicine or my cholesterol? How long to do this? Well, as long as you got a problem with it, we need to control it. We certainly will. And once we get to a point where patients are happy, they're happy to continue on.
And let's bring up the next picture. Again, you can see the difference in this young lady.
This is a fascinating picture because on the picture on the left, yeah, she's got acne, but it's not terrible, but you know, it's significant. But the other thing too that's very interesting is when you're dealing with skin of color, you're dealing with a whole different problem. You're dealing with a thing called post-inflammatory hyperpigmentation. Oftentimes with brown skin, when the blemish resolves, it leaves a brown spot. And it's very important to discuss with your patients that you're really dealing with two processes, both the inflammatory or active acne, the bumps you can feel, but also the brown spots. And I've seen many times, as a physician you take it for granted, but I've seen many times I'll treat a patient well with an acne medicine, so all the bumps are gone, but they come back and they're still kind of upset because they still have brown spots. And to them, spots, bumps, it's all the same, I still have acne. So I say, listen, we're going to go after two things. First, we're going to get the acne nice and quiet so your skin is smooth. And then secondarily, we'll use a different medication to fade away any brown spots. Now, normally the brown spots, when you have an acne blemish, will fade in a few weeks, but in some patients it can last months, sometimes even years. And so then we'll use different medications to fade that away. When there's an old medicine we've talked about already called Retin-A, and it's a retinoid. So back probably in the late 60s, early 70s, there was a professor down in Georgia at Emory University, and his name was Kligman. He actually invented the field of vitamin A products to treat acne. But he had a resident who was African American who said, hey, listen, when we have patients of color, they also get these brown spots. Let's try and see if we can fade those away. And so they looked at Retin-A, and it actually would fade away the brown spots a little bit, but the problem was it's really irritating. There's another medicine called hydroquinone, and that's available in a lot of over-the-counter products, in fade creams you can get online and things like that. So they put the two together to see if it worked better, and it did. But it was really irritating. So then they said, well, let's put a mild anti-inflammatory with it. So they put three things together, and it really hit the jackpot. And so that's what we use now, a combination of two different lightening agents and an anti-inflammatory agent in patients like her. And you use it twice a day for a couple months, and it fades away the dark spots.
Okay, let's bring up the next one. And hopefully, there we go, young lady, I believe.
Young man, young man.
That's a young man.
But you can really see what a difference it makes. You know, he came in, he hardly would look up at all, wouldn't make any eye contact, and by the time we were done, he's ready to conquer the world. And so many times I'll have patients and the parents will say, well, just tell them they need to wash their face more and tough it out. That's what we did when I was younger. And I'm thinking, well, you know, washing your face is not what's going to solve the acne problem, but it's always good to have clean skin. And when we were younger, we didn't have great things to treat acne, and now we do. So you don't have to tough it out anymore.
That's one of the things I was going to ask you, and let's bring up the next one, is that it's not merely lack of washing the face that creates the acne, it's really the hormonal change.
It's the hormonal change and those oil glands that are producing deep in the skin, and when you wash the skin, it doesn't get down deep enough to affect that. Now, if you have soil on the surface of the skin that's plugging the pores, certainly by cleaning it, that'll help from making it become worse, but that's not the underlying cause.
This young lady, let's talk about her.
Yes. Now, if you notice in hers, she mainly has a lot of pustules on the forehead, kind of the bumps with the little whiteheads. And that's when you have lots of inflammation, and those are the helper cells that come called neutrophils, and they come into battle and they die, and they leave little pustules. So in this one, we're using a real strong anti-inflammatory component. I use a strong anti-inflammatory topically, and also an oral medication that was anti-inflammatory. And we treated her for about 6 months. This is the first pictures before, and the other one's about 6 or 7 months later. So it was about half a year to turn this around, but she had a very nice result.
And you can see how happy she is to take that second picture.
Yeah, I didn't notice that when I was taking these pictures originally, but if you look at the before and after, the afters are almost invariably smiling, just beaming, and the before is, she's putting on a nice face, but it's not the same smile she had afterwards.
And let's bring up the next one. I think we have a few more. Okay.
Now this one is interesting because she really had a problem with lots of blackheads and plugged pores, and so we used a real strong topical retinol or vitamin A cream to unplug those to get things going, and that made a big difference for her. This is probably about a 5-month change, but for her we did strong topicals to unplug the pores and then an oral anti-inflammatory to calm things down.
And she appears to be more adult than some of the others.
Yes, and that's a great point because we recently had a patient who called and was very, very, very concerned. They said that the acne medicine that we had prescribed for her insurance company will no longer cover it for anybody over the age of 18. And I mean, that's complete malarkey. I treat patients with acne into their 20s, 30s, even 40s. And so to say anybody over the age of 18 can't have acne, I think whoever's making that decision is misinformed. So I would encourage the insurance companies to do what's right for your patients and members out there and give them the right medicines. But anyway, so
sometimes, however, those decisions are made by people who are non-medical people.
Yeah, which is unfortunate, and that's why, as physicians, we really, and this is where my staff comes in, the great staff. They're great advocates, and they'll contact the insurance company, and they'll get an approval thing called a prior authorization, but it takes a lot of time and effort to get it done. But in her particular case, she was probably in her mid-20s, probably 25, 26, 27, so a typical case of acne that's not limited to the teenage years, and it's under hormonal changes, too, and hormones can change for many, many years.
Do we have another picture? I think we do.
That might be it for today?
No, I think there's another one. No? Okay. The director is shaking her head at me, saying we've run through the gamut.
Well, I think we got a good review there.
Yeah, certainly a good cross-section. And you talk about your staff. You have a large office staff. I would guess between 30 and 40 people.
Yeah.
And yet every one of your patients is treated by you.
Correct.
There's not one of these offices where there are 4 or 5 dermatologists in there. Everybody who comes in to Crutchfield, and I'm not advocating or advertising for you, but the fact of the matter is everybody that comes into Crutchfield sees Dr. Crutchfield. You're usually trailed by a resident from the university, but you are a clinical professor there. And
And I realized I had to learn somewhere too. So that's why I've made such a strong commitment to teaching. And we always tell our patients, we'll put a sign out that we've got a medical student or a resident shadowing today, and if it's inconvenient, we're happy to reschedule for them. But most patients are great about it.
Mm-hmm.
They realize too that you've got to train the next generation of physicians to come along and keep helping people. So, and our residents and medical students are very respectful, and they're very bright. A lot of times they'll bring up some points that are interesting too. But with our staff, the way we set it up is, I remember when I was a resident, we looked, and when I did surgery, the surgeons, they like to operate, and I give them credit, and they're great at it, but they don't like to write a lot of notes. They'd rather be in the operating room doing surgery. They don't want to be writing notes. And so what a lot of hospitals did is they would hire scribes for them to help them do the notes, and the surgeons would operate, and the scribes would help them do the notes. And so we kind of developed a system like that. So I've got staff that'll help me do the note-taking and really support me. There's a term called physician assistant. Well, my staff really works like physician assistants. They help with the note-taking, but once again, I'm dictating it, but they're writing it down. They're not making anything up. They help with educating the patients on what medications to use, how to use it. They give patients their cards, say if you have any questions, call me directly. They help fax in and call in all the prescriptions. So they do a lot of support things for me, which enables me to really do what I do best, and that's to look at the patients, make the diagnosis, and come up with a treatment plan that's best for them.
which is why you have been designated as one of the top dermatologists in the country.
Well, I think that's very kind for you to say that, but I think the main thing too is the system works so well, and we have all these other systems. My father is an obstetrician gynecologist. He still volunteers 2 days a week. He's still practicing, and he's delivered almost 10,000 kids in St. Paul. I'm so proud of him. He's made it so easy for me to practice medicine, to come behind him in the same city with the same name. The battle's halfway over by the time I just say my name. And my mother was a family medicine physician. She's retired a few years ago. But
Wasn't she the first female graduate?
Yes, my mother was both the first African-American female to graduate from the University of Minnesota Medical School in 1963, but at the time she was also the youngest graduate in the history of the University of Minnesota Medical School. She finished medical school at age 22. And at those days, you didn't do a residency, you would join a small group, kind of like an apprenticeship, and go on. So she was an attending at St. Mary's Hospital, Minneapolis, at age 22 as an African-American female in 63, really before the civil rights movement took full effect. So I'm very proud of my mother, too. But my father said when he was about to retire, he joined one of the local hospitals, and they told him that they needed him to learn their electronic medical record system. And the difficulty, he said, was, son, I spend 20 minutes with the patient, but then I spend 40 minutes with the computer trying to document all these things. And my brother said the same thing. He's gone to see doctors, and I've heard this from patients alike. He said a lot of the physicians, tick, 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 they're clicking in the computer, and my brother knocked on the monitor and said, hey, I'm your patient, I'm over here. And so I think it's really nice to have a system where you can interact a lot with the patient. Let the support staff do all the support work for you, but I think it's really important to deal one-on-one with your patient.
Now, as I mentioned, we just came back from Mexico. A great week to be away, by the way, but one of the big problems, apparently, in dermatology today is skin cancer. And still people keep going to tanning beds. How do you deal with that, and what can you caution about it?
Well, here's the thing. Here's the bottom line. There is no such thing as a safe tan. That does not exist. And in fact, and I hope your viewers will bear with me a little bit, in order to get a tan, you think about it, why would the skin get dark? Because it absorbs sunlight. And so it's your body's natural way of saying, hey, I'm getting damaged, I need to try and put up an umbrella to protect myself. So you have these little packets of melanin, and when you get a whopping dose of ultraviolet radiation or sunlight, it releases it. And if you've ever had a suntan, you'll notice there's two bumps. You'll get a darkening right after you go out in the sun, maybe an hour or two afterwards, and then about a day later you get another little bump, and that's because you already have some ready to go, and then your body makes some more. But the only time your body makes melanin is when your DNA is fractured. Now think about that. You have to have broken DNA to get a tan, and you have these little pieces of DNA, and they hit the special organelles in the cells, and that's what produces the color, melanin. So there is no such thing as a healthy or a safe tan. It's all because your body is doing whatever it can to protect itself, and the accumulation over time with all this DNA damage sets you up for skin cancer.
Is that where melanoma comes from?
That's exactly it, where melanoma comes. It's cells that produce melanin that are defective, and they become malignant, and they grow, and they go to other organs. Now the thing about melanoma, if you have melanoma right by itself, that's not a bad thing, but melanoma is so vicious and so terrible. little pieces will break off and travel around in your bloodstream and lodge in other organs. It'll take over your lungs, your liver, your brain, and that's what you die from, the metastasis of melanoma. Now, the one thing that really gets me is with the tanning beds, and thank goodness with the efforts of the Minnesota Medical Association and the Minnesota Dermatologic Association, they passed laws this year that if you're under 18, you need a parent's permission in order to go tanning. And it's kind of, it's the equivalent of cigarette smoke. You need to be a certain age before you make that decision.
These kids want to look better.
They do, and I understand.
They'll do it at all costs,
I
and
get it.
sometimes that cost is fatal.
It's fatal, and I get it. You've got the peer pressure, and let's look good now. I can worry about skin cancer 30 years from now. But there are great products right now. Spray-on tans and self-tanners and sunless tanning, they look great, and they don't cause any DNA damage, and they don't give you cancer. And the one thing that's very fascinating to me is there's a big argument from the Tanning Bed Association that all these greedy dermatologists, and they're saying all these things about you shouldn't go tanning, they're completely wrong. And I'm thinking to myself, actually we're being very altruistic. If we really wanted to beef up our business, we say, go tanning, and then we'll have all these skin cancers to treat later. But of course that's not true at all. So we're doing what's best for the patient.
And as it should be.
Yeah.
Right. Well, one of the really beneficial things for our viewers is the fact that, notwithstanding your national reputation, you have an office right here in Eagan, 1185 Town Center Drive, unless I'm mistaken.
That's it.
And it's always busy. And times when I have been in the building and I've looked in, it's always busy, but these people know that they're going to get to see you when they come in there.
And that's my promise. And I think it's the nature of the business too. Dermatology, they did a study at the Mayo Clinic about a year ago. That is the number one reason for a doctor's visit, skincare concerns. More than high blood pressure, more than high cholesterol, more than back pain, more than headaches. That's the number one reason for going to see a physician is skin.
And yet there aren't enough dermatologists.
And that's a problem because only 1% of all doctors are dermatologists, and you can't change it like that because you've got to rev up the training programs, recruit more residents, things. So it's a challenge. It's a challenge. And right now it seems like there's more dermatologists retiring than there are being trained. So we've got to catch up on that.
Well, we certainly have to. And you're right there at the university. And
Yep. I trained at the University of Minnesota, trained at the Mayo Clinic, and I'm always happy I teach the residents and also the medical students on a regular basis.
And you also are the sports doctor of skin conditions. As a matter of fact, you were scheduled for an interview here.
That's right.
And my favorite twins called you.
That's right.
And you had to fly down to Fort Myer last year, just about this time, or a month later, to treat somebody's skin condition with the ball team.
Yep, and so we still work with the Twins and the Vikings.
And they did
the
so
Wild.
well that they lost 96 games.
Yeah,
But,
I better do better next year.
I think they will do better this year. We've been talking, and I have so much more that I wanted to ask you, and we got into this discussion, so I'm going to ask you again if you'll come back in a few months and
I
continue
would love
this
to.
with.
It's my pleasure. We can talk about other skin conditions. I don't think we'll run out. There's over 4,000 skin diseases, so I think
We got a lot of
good
programs
list.
to go, and we've
Good.
only done 1,600 so far, 1,700. So, Dr. Charles Crutchfield, Eagan physician, outstanding dermatologist. A pleasure to have you, and we'll see you back again.
No, the
soon.
pleasure's all mine. Thank you.
Thank you. We get off with a second despair.